It's my absolute pleasure to talk to you today. And what I'll be sharing is two toolboxes that I feel help me a lot in talking the talk and walking the walk when it comes to withdrawal life-sustaining treatment on intensive care. Now, some of you may know these tools through the Deceased to Nation course, and that's all right because I'm hoping to give a new angle on this, or at least remind you of them, because I still use them both in my daily practice and have used both even this week. So let's talk about talking the talk when it comes to withdrawal life-sustaining treatment. There's many background we can think about: the when, the who, the where, the what, and the why. But this talk, I want to focus in on the right structure, how we structure and the delivery of breaking bad news, talking the talk. And really the ideas for this came out of our observing and our supporting and our really reflection on our own practice from the Deceased to Nation course. And what we realized on that course, that it's hard to structure these conversations. It's hard to get them right, but you do need a plan and you do need a structure. And I call it a toolbox because it's not a recipe. You can't just do add this and add that, and the conversation will go really smoothly all the time. But you have to have tools in your armamentarium to approach families and deliver a bespoke communication to really aid the families in their understanding and in helping yourself explain what needs to be explained. But what came to us is watching conversations on the Deceased to Nation course and reflecting was the concept that human beings are storytellers. One of the fundamentals you'd always ask yourself is, what story are you telling the family? Telling stories is evolutionary. Telling stories is how we as human beings digest facts, especially emotional facts that really impact upon us. We tell stories to understand the world and to understand what's happening. And if you think in terms of your communication as a story, which may be over many days on intensive care, but the one I'm focusing in today is on a breaking bad news conversation and the bits and components to that. Think of it in terms of a story and telling a coherent, logical story which will make sense. Because as soon as you're done with the story, the family are going to pick up a phone and they're going to ring someone and they're going to relay a story. And the words they will use and the ideas and the themes will all be based on the story that you've helped them understand. And that's why it's so important. And we are storytellers. We are storytelling animals. So who's a good storyteller? Well, William Shakespeare is a good storyteller. And I think there's something in the way he tells stories and in the way the stories are still told today in our movies, in our TV, that points to something deeper, points to the fact of the way we tell stories and the structure we have in our stories. It's not just there because that's how it's done. It's there because it fits, it points to something deeper than that. And this sort of came out again when a colleague of mine, his name is VJ. He came as an observer to Nottingham, and he comes from Croatia, and he shared that Croatia, that there's not a culture of withdrawal or life-sustaining treatment. In fact, over COVID, it was pretty horrendous because they wouldn't withdraw and they just would continue and continue until the patients had a cardiac arrest, was what he told me. But a new law has been passed which allows legally withdrawal of life-sustaining treatment on their intensive care. But they've got no history of that, no culture of it. And he was really keen to come to Nottingham and observe the way we break bad news. And he's really taken the Shakespearean tragedy, the three-act structure, and he's made it into the diagram you see before, which is very, very helpful, as well as he's actually shared it on the new Ficum Trainee Eye, just published in autumn 2023. So how does this work? Well, let's think in terms of our three-act structure. And if you go to a play like by William Shakespeare and many other plays, it begins with a prologue. Romeo and Juliet, a pair of star-crossed lovers, take their life. It's quite clear right from the beginning, in the first couple of sentences, that this is a tragedy. This is not going to be a happy ending. Star-crossed lovers will take their life. And there's something important happening here, and that's what the prologue sets up when we break bad news. But you need to establish with the family, it's a tragedy. It's not an action rescue. It's not, we sit down and go, they're very sick, but I'm Dr. Gardner, and I've got just the new treatment that's going to save them, like an action rescue. Sometimes it feels like a crime drama. Well, if the GP had only done this, and then if the A&E had done that, and it's like, who's to blame here? That's the crime. That has to be. There's a crime being done, and there's obviously therefore a criminal, and the family need to find out who that is. Establishing you're in the right play, the same play with the family, is essential. But we often use the word ask the family, can you tell me what you know so far? And I've seen that in practice, it's as good as saying how you're going. It's not doing any work. So when you come to a family and say, can you tell me, can you explain? I know you've been through a great deal in the last few days, but can you briefly tell me what your understanding of what the situation is and what has happened to Michael up until this time? It's vital that we think in terms of what is that sentence? What are we doing here? Well, we're doing two things. We're first of all establishing that we are all in the same play, because the answer they will give you will tell you, yes, they understand this is a tragedy. That's why we're having this conversation. And that allows you to move forward. And we'll talk about the second point in a second. But often in this time, it's important to give a warning shot. I'm afraid the news isn't good. Be prepared to hurry on. But nonetheless, we enter into the 3-act structure of an importance of we take what the family says. And this is the second part of why you ask what the family knows so far. We take what they have told us and then we retell it, building off what they've told us. As you said, Margaret suffered a very bad bleed in her brain. As you saw, she lost consciousness almost immediately, and the paramedics had to put a breathing tube in because she was no longer breathing for herself. We're retelling the story, but layering on the aspects that make this a tragedy. Since coming to hospital, we have not seen her breathe, and many of her brain functions appear to have ceased. And then the most important thing we'll probably say as we're retelling it, and we sum up, we've been very worried, because when the doctors are worried, then everyone should be worried. Such a powerful, honest statement that sums up so much. And we keep telling the story, and what we are building towards is what we call the telegraphed reveal, where we're building up and up until we're going to say the words such as potentially like this: the scan of Margaret's brain is very abnormal and devastating. My fear is that the damage Margaret has sustained to her brain is so severe that she may have already died. And then silence. She may have already died. Silence. Why silence? Well, we know in grief that people's thinking slows, and so slowing down is so important, but it also gives the emphasis on the most important bit, the reveal. But it's been telegraphed. We have built off the story the family have told us, building and building to this point, and the family have been going, yes, that's right, yes, that's right, to this. It's still devastating, and it may be a shock, but it shouldn't come from left field, be a total surprise, because of the way we have built up. So one question is, how long do you give the silence? Well, my rule of thumb is, if it doesn't feel uncomfortable, it hasn't been long enough. And you should, wait for the family to break the silence. And they probably will break the silence. They generally do in one of two statements. Why is this happening? Now, there's a tendency here to go, well, there was an aneurysm, and when the blood pressure, and it popped, and no. This is a metaphysical, why is this happening? This is a why, God, why? And your answer should be, it's just so unfair. This is terrible. Answer in that sort of way. The other common question that comes out at that moment when the family break the silence is, what happens now? And there may be a tendency to launch in all your plans of extubation and coroners and even organ donation at this point. And it's like, no. What you need ideally do is guide the family to accepting an interval. Now, intervals in storytelling, intervals when we go to a play, are not just there to sell ice cream. They're there also because after that big buildup of tension, there's a way of relieving the tension by having a moment out, but also that is when true understanding comes for the family. And our nurses are so invaluable at this time for that gentle reassurance, the gentle retelling of your story. So if you haven't done it quite as well as you might have hoped for, and the family haven't quite followed you, or the family don't understand, the nurses are so strong there, and having, you know, the fact that things change and more relatives can be by the bedside. It's all helping them to understand and accept. Now, I call this a toolbox because not every family is going to sort of want that interval. But I think many families want us to take them by the hand. They've never done this before. We have. Take them by the hand and say, what happened? When they say, what happens now? Say, now I suggest you go and spend some time with Michael. Then we will come back and talk some more, and we can plan his end of life care together. Try to guide them towards accepting a break. And then you come back. And it's then when you come back in Act 3, when you can resolve the story, talk about end of life care planning, which may or may not consider organ donation and tissue donation. But actually, you know, that's when you can talk about, you know, spiritual support, other family members, bringing children in, all the other aspects, coroners, all the aspects of procurator fiscals, all that may come is so important to have that time then to separate it into that aspect. So that's the Shakespearean tragedy. It's a structured approach. It's not a recipe. It's a toolbox. But one question we've been asked is, how does this work in a sudden death on ICU when the person's died? It wasn't expected by potentially you or the family, and you have to ring them up and tell them that their loved one had died. It's very hard, and there's no easy way to it, and it will all feel like a backward story, and that's because it is. But we've all seen movies like this, which begin with the death of the main character. And the story, in the end, is all about the how. So I suggest it has to begin with a reveal. You have to begin right at the end, in that Act 2, the reveal. Give a warning shot. I'm so sorry to call you. I've got some very bad news, or I've got some terrible news. And then you deliver the devastating news. Then at that moment, whether you want it or not, because the nature of this, there is going to be an interval. Now, that interval might be the family come in straight away from home to see their loved one, or it may be you're meeting them in a bereavement meeting many weeks in advance, or you may be meeting them in coroner's court months and months in the future. But nonetheless, at some point, someone, if it's not you, will have to tell the how of the story. And the how is trying to get the point we're trying to reach with the how is, I think, back in Act 3, we're trying to reach the point where there's an ability of the family to move forward. So I still think the 3-act structure can be played even in this backward story. And then we have a prologue where you meet the family again. If it's like soon after the death and they've just come in, and you might say something, just an empathic word, I'm so sorry, and then potentially invite them immediately to see their relative, and then start talking and moving into explaining the how. But sometimes if it's been a lot longer, you may be meeting the family for a bereavement meeting. I often start with, how have you been? It's an empathic statement, and I can use it in the prologue to judge, why does the family think they're here? Do they think they've to talk about the tragedy and so they can understand the tragedy? Or are they in the situation, this is more of a legal drama, a complaint, gathering information for a legal complaint or other aspects? And it's a very easy way to rapidly work out, what are they hoping to get from it? And plus you got the opportunity to ask them something human about how they've been. And then, just like previously, you have to retell the story. And just like those movies, we're going to keep retelling the story until we reach the point we were at the beginning, which is the death of their loved one. And then at that point, often there will be another interval, and that interval will be the family will go home. And our hope is that they will go home and have the ability to move forward through their grief and into the life to come. So I think even in this backward telling of the story where there's a sudden death, you can still use this toolbox to help convey and communicate in a structured way. But I want to talk about something different now, which is the walking the walk, and to use the other thing I use in my toolbox. And there's a great quote. It was easy to make a heroic gesture, but hard to abide by its results. And that's the challenge, isn't it? To when we're walking the walk with the withdrawal of life-sustaining treatment on intensive care, it's easy to say words like, in 3 days' time we'll do this, and hopefully someone else will be there. It's much harder to walk that walk, and to also to actually be able to face the decisions we make, even what long after the fact. So I feel very strongly that ethical decision-making tools have a place here, both in the making of decisions, but also in the retrospective considering decisions. I chaired Nottingham's ethics committee for many years, and often clinicians would bring cases to us that had already been resolved, but they had moral distress, and talking through it and working through like a framework really helped them to explore that and come to terms with the decisions that were made and feel justified with the decisions that they did the best under the circumstances. So there are many tools, and I'll talk about one of them in a second, but also sort of highlights the end-of-life care guidance that's been jointly published, and that's extremely helpful as well. But let's think about this a bit more, because we're at work, everything's well structured, we're sort of quite, with days going on, and then often things come out of the blue and upset us. And my colleague Dan Harvey, who did a lot of this work with me, he talks about sometimes being up at 2 o'clock in the morning or waking early and just heading downstairs for a cup of tea. So not so much in the morning, but in the evening, I find myself sometimes leaning for a glass of red wine, Australian red, naturally. And these are decisions that are quite difficult, and it's not. I'm never worried about, should I give vasopressin or NORAD or a bit more adrenaline, a little less of that. They're not the decision. It's these difficult walking the walk that actually, they're the ones that keep me up. Did I make the right decision? And because good decisions, really help. If you make these decisions, you can reduce fallout and reduce stress. And in many ways, our role is also to be supportive of the team. And I find as a doctor, my role is to support my nursing colleagues, everyone in the team around me. And it's got to be a joint effort, and we need each other here. And I really believe that we're stronger when we're working together as a team when it comes to these conversations and also making these decisions. So the framework we have taught for a while now, and it's taught on the donation course, is called the Moral Balance Framework. And it's based on the old 4 principles of autonomy, beneficence, non-maleficence, and justice. But in many ways, we often haven't been taught how to apply them into action. So I'm going to go run through a case and show how I might use them and how I use them regularly. So it's Monday morning, and the balls are falling down. So here's the case. Simon, and it's an imaginary case. Simon, a 27-year-old male with a history of schizophrenia, hung himself and suffered hypoxic brain injury. His pupils were fixed on arrival in ED. Emission CT showed early signs of hypoxic injury. He's now 3 days in ICU, GCS 4, motor score only 2, myoclonic jerks, repeat CT, severe hypoxic injury. Simon's mother is not accepting of the poor prognosis. So it might be an imaginary case, but it is a common case, sadly. And now it's Monday morning, and Simon is now your patient. What are you thinking? Well, this is where the moral balance mnemonic can come in and help you walk the walk. It starts with the M, which is make sure the facts. So what are the facts here? Even just laying them down can really help. Well, the fact is Simon has hypoxic injury in the CT. He's got poor neurological signs. Other investigations, well, he's relatively young, and his prognosis is poor, but is it hopeless? We think so, but how certain are we? And maybe that's when we need to think about those other investigations, maybe. There's other background here. We've got a psychiatric history. We've got a social history coming to us that the mother's not accepting of the poor prognosis. Why? And I think laying out facts, even when there's question marks, is really helpful, because that tells you where you need to dig into. And there's, things are really jumping out on me. Where do we need other investigations? Why is the mother not accepting? What's the legal position? Best interest? Well, potentially that's, relatively established in law. Other investigations, do they have a role? Well, here's my little Dale's UK straw poll of neuroprognostication, asking 11 colleagues around the country. Neuro EEG, very commonly done. SSEPs commonly. One place says one of my N equals 11 did a biomarkers where they says it take a week to get the answer, and they weren't that impressed. Clinical examination, well, everyone's doing that regularly. Everyone's probably repeating the CT. Occasionally people are doing MRI. Pediatrics, it's more common. But a more fundamental question I would say is, why are you carrying out additional investigations? I think this is a really important one. Ask yourself, why do we need a new investigation? Is it because you don't know the prognosis? Are you trying to exclude the reversible? Are you just reassuring yourself? Or is it reassuring or convincing for the family and doing it for the family? Or you just want to share the blame with someone else? And this great quote from Christopher Palace in 1981 still rings true. Many American jurors have a touchingly naive faith in the supremacy of machines. I think in many ways, sometimes we know better. We want someone else, some magic number to tell us the answer here. Then the moral balance asks the question, what are the outcomes of relevance to the agents involved? Well, an agent is anyone who has a moral stake in the outcome. So what about the patient? He wants to live, we think, but then he was potentially committing suicide, but he did have a mental health problem. So there is sort of some confusion and question about this, but generally, if he was fit, if he was well mentally, he probably would want to live. And so I think that's still important. The quality and independence of that life, now he has a brain injury, is equally important. And it's often not a binary live or die. It's on that Sudoku puzzle there of what sort of recovery he may get. But when people aren't going to live, most people would like a good death, free of suffering, with their family nearby. But what about his mother and the other family members? What do they want as another agent? What are the outcome of relevance for them? Well, to live. They want she wants her son to live. But often when you talk to family members, they also don't want their relative to suffer. And she would value the quality of life if he does live. But also, I'm sure she's very wanting to know that everything that could be done wasn't done, was done properly, and we weren't sort of cutting corners. And therefore, there's an argument that more time could be helpful to show, so she can believe that everything was done that could be done. And of course, grief and guilt in this very difficult situation, guilt of what's happened in probably the years before, and grief for what's happening now. Many, many emotions. What about you as healthcare staff? I think we want to do good, and it can be really upsetting when we feel like we're not doing good. But we don't want to get in trouble with someone blaming us. We are worried about resource costs because there are other patients who may need us, and we have a limited resource in intensive care. And we want to avoid moral distress. Doing something that we don't believe is right for the patient can be a huge source of moral distress, which is well linked to burnout. We also think about society. What do they want? And what are they want us to preserve life, but not at all costs. They want fairness and non-discrimination, and they want us to use our resources well, to steward them well. And then we can bring it all together and make sure the facts, the outcomes of relevance, the agents involved, and level out the arguments using a balancing box. And this is to just use the four principles. Of course, I can't spell non-maleficence, I just write burdens. So this is the question: should we give more time to Simon? From the autonomy, bringing through our facts and outcomes of relevance. Well, the autonomy thing, we said it was to live, but there was a slight question, but generally to live. But we've learned from his mum and the quality of that living and the independence of living would be important to him. And if he's not going to live, then a good death would be of value. But the burden of giving more time is maybe we're going to end up with him just persisting in the mission creep of ICU, leading to him living, but in a poor quality or dependent state. We may prolong his suffering by continuing our treatment. We may prolong family grief and the time by giving more time. But the benefit of more time might be more certain prognostication, that maybe there is a higher chance he will live. That even a higher chance maybe we got it very wrong, and he might have a chance for a good outcome. Also, family grief and time may be benefited, maybe reduce family grief by knowing that all could be done, was done, and giving that more time may reduce that grief. And then justice, the fairness, non-discrimination, resource stewardship. So I ask myself usually when I write this down, and I just write it on a piece of paper, and I only did it yesterday on another patient on my intensive care. I don't file this. This is for my to aid me, and then you'll see how I document in a second. But I ask myself when I look at that, is there anything of particular note? What is jumping out? And for different people, different things. But for me, what jumps out is certainty of prognostication. We need to be certain of that because everything else will follow that. And if I'm not certain of the prognosis, it's very hard to interpret and to move on with the other aspects. But I think, where is the greatest conflict? What I'm often looking for is where there's the opposition between the boxes. And I think there's big opposition here between Simon would want a quality and independent life, but our risk is by continuing on, we're just going to give him the opposite, a poor quality, a dependent life, and that we won't give him a good outcome, which is what he would want. The other thing is, watch out when there's words on exactly the same words on both sides or diagonal bits of the boxes. Family grief and time. By continuing the treatment, we may end up increasing the grief of the family and just delaying everything. And the benefit of more time is we may minimize family grief, and we may giving them more time may be a benefit in everything. So you can sort of see there's a conflict here, and that shows us we need to think carefully about family grief. And if we are going to continue, how we're going to minimize any regret from that doing that. And where's the greatest congruence or agreement? I think it falls on here that if he's going to die, he would like a good death, and prolonging suffering. No one wants that. So it was easy to make a heroic gesture, but hard to abide by its results. So when you face that Monday morning with Simon, you could just write, as some intensive care consultants once did in the past, the prognosis is bad, withdraw, my decision. Or, as other intensive care consultants do, and there's always that fear that you fall into it yourself, I need X plus Y minus Z, and then after T days, and were Venus to align to Mars, basically meaning that behind the message, I feel very uncomfortable making these decisions. So I will kick the can until the problem goes away or onto someone else. But we are going to have to make a decision that morning on Monday. So what are we thinking and how do we approach it? And importantly, how are we going to document it, that decision? Documentation is so important. And when going to tell a different story, it's not going to be that sort of building structure to a story. We're going to tell just a logical through few statements. And I think an ethics framework or any framework can really help with that. And this is how I would approach documentation. Facts and prognostication. I wouldn't write that facts and prognostication to the side. I just would write what's in front of you. I have reviewed the history, examined the patient, and reviewed the images and EEG report. Sadly, at 72 hours with the GCS-M2, presence of myoclonus and CT findings, this all supports a conclusion that the prognosis is extremely poor. The EEG demonstrates severe brain dysfunction consistent with hypoxic injury, with no signs of confounding seizure activity. I would expect Simon to at best be left with severe, life-changing neurological injury. What are the outcomes of relevance at this point? Because, well, I've spoken to Dr. Smith, neurology consultant, and my ICU consultant colleagues' names. They share this sad prognostic conclusion, helping us be sure in the outcomes that we have made the right decision by documenting in this way. And then thinking about Simon's mother. From early discussions with Simon's mother, we have established that Simon would not wish to be left in a debilitated and dependent state. Sadly, this is the outcome we expect. I understand that Simon's mother is struggling to accept the poor prognosis. And now to the decision. The MDT conclusion supports the withdrawal of life-sustaining treatment to be in Simon's best interests and changing the focus of treatment to comfort care. Deputy Sister has arranged for Simon's mother to attend later today and to bring a close friend. We are also arranging chaplaincy to be present as way of support. With family agreement, we would proceed to extubation and palliation. Snots are aware. And that is how I would document this. Not a he said, she said, and then like a long story, but just use the structure of that framework, that ethical framework of decision making to now document my decision. So I hope these two toolboxes have been helpful. They certainly are, and I still use them actively in my intensive care career. The sort of Shakespearean tragedy, approaching those Breaking Bad news conversations with a structured approach to building up and delivering the news, and that silence and the interval being so important. And using ethical frameworks, there are other ones, to really help you walk the walk, to live with your decisions, to make decisions. These two toolboxes I commend to you as being helpful to me and hopefully helpful to you. Thank you.